Hi, everybody. I'm here with Ney, who is actually from Brazil, and he's visiting Canada for 1 year. And we are attending the same conference, the Canadian Pain Society conference here in Toronto. And I could not miss this opportunity to interview and talk to you, Ney, because you are doing amazing things for people with low back pain. So, Ney, thank you so much for agreeing to talk to our audience today. And I'd like you to introduce yourself and talk about, what is your position, where you work, and what are you doing here in Canada?
Thank you for having me, Andrea. I am a visiting professor at McMaster University and also an assistant professor at Augusto Motta University Centre in Rio de Janeiro, Brazil.
So, Ney, why did you decide to become a physiotherapist?
As a person with lived experience of musculoskeletal pain, I've had some experience with my ankle sprains, recurrent ankle sprains when I was a teen. And after the fifth time, I got chronic ankle pain, which is not very common.
Chronic, both ankles or?
Both ankles.
Both ankles.
But the problem was that I was not able to play soccer.
Oh, that's a problem for Brazilians.
Yeah, I was afraid of having another ankle sprain. Whenever I jumped to head the ball, I was very afraid of having a new episode.
Because each episode that you had lasted a long time?
Yeah, after the fifth time, I remember that I was not able to play soccer because I was feeling fearful of having a new episode, and I got like a very mild pain, but I felt unsafe.
How old were you when you stopped playing soccer, more or less? How old were you?
I was 14 years old, and 15, and it was like a trigger to start to think that, the physiotherapy that I was having that time, like with ultrasound, ice, and a bit of mobility exercise, was not effective. So by instinct, I started to perform a treatment by my own.
Oh, wow. You invented your own treatment?
Exactly. I don't know. I can't remember how, because there was no internet that time.
No internet, no Google for you to find
Exactly.
answers.
So I decided to start a treatment based on the most fearful activities, like jumping to head a ball and using balance exercise, like proprioception exercise, and all the movement I would have to perform during a soccer game. And after that, this was like I started to play again, and I have never had another ankle episode. Nowadays, I can't even remember that I have ankles.
And then you decided to become a physiotherapist.
Exactly. It was the main reason. Maybe if I was able to do that, let alone if I study for that, I'm going to feel that, maybe I can help people.
Yes, so then did that kind of spark your interest to help people with chronic pain, even after you did physiotherapy? How did you become involved more with chronic pain?
First, in my first year as a physiotherapist, I started osteopathy specialization. I studied that for 4 years, and then I realized that I was able to treat acute and subacute with more passive techniques. And of course, most of the time I was helping people, but most of their improvement was because of natural history of improvement.
Can you explain that a little bit more? Because maybe some people will not know, but let me see if I can explain.
Sure.
So acute pain, when we have an acute injury, our body will heal naturally, and we call that natural history. And then if a person has received a treatment during that normal healing process, they think it's because of the treatment they received. Is that what you're trying to explain?
Exactly. For example, spinal manipulation, you know that it's recommended, but most of the times, if the person waits a little bit more, they improve either way.
They will improve with or without the treatment.
Yeah. And so I realized that the most challenging patients are the chronic ones. So that's why I started to try to find treatments, effective treatments, to help people with chronic pain, chronic spinal pain.
Yeah, that's very interesting. I think I never talked about this in my channel before, Ney. The natural history of acute pain is to get better. The symptoms, the body heals, and then the symptoms get better. But for some people who develop, not everybody who has an acute injury, there is a minor proportion of people that will develop chronic pain. And then they have that chronic pain. Their natural history is not to get better. It is to remain the same or to get worse because of all the comorbidities, the depression, the lack of movement. They start restricting themselves. So yeah, that's a very important thing. I think I never mentioned this in my channel before, the natural history of things. Thank you for mentioning that.
Problem, exactly. So I started to realize when I was during my master and PhD in epidemiology, I realized that not chronic, but low back pain in general is one of the the management of low back pain is not good. So in terms of disability, so I realized that, my treatments are probably not helping these people. And since my comfort zone was to treat patients with acute or subacute, and then when the chronic low back pain patient knocked my office's door, I didn't know exactly what to do. So the same treatment, passive treatment, and even if I included some exercise, I helped them, but in a very small amount.
This might be what a lot of people who are watching this, they have chronic pain and they're going to physiotherapy. They come back, I see them like in a consult, and they say, oh, physiotherapy doesn't work for me. Might be because that physiotherapist is well-intentioned, but is using passive modalities or some exercise that are good for acute, subacute back pain, but not for chronic back pain. So Ney, I think the question is, what is your approach? What did you find that works for people with chronic back pain in your career? You are also a researcher. You publishes many excellent, high-quality studies looking at this. So what did you find? What did you learn? And how can you help people who have chronic back pain, which is different from those passive modalities? When we say passive modalities, I would say those are things like the physiotherapist would apply to the patient, right? Like what? You mentioned ultrasound.
Manual therapy.
Or manual therapy, they will do massages or manipulations.
And sometimes exercise focus on posture. Bad posture,
those electrical stimulations as well.
Core training.
Getting the core stronger. So those are good for acute, subacute.
Yeah, maybe. Some of them.
Okay, so what is your approach for chronic low back pain?
I think the first thing that is important is that there are maladaptive beliefs, like negative beliefs about chronic spinal pain. Most of the times they're produced by an MRI scan, like someone talked about the MRI scan, saying that there is something wrong, and you know that you talk about that a lot on your channel. But in physiotherapy, we have the idea that posture is a big issue. Like we try to find like biomechanical issues to explain the pain. So we have to shift.
I have a video about posture.
We have to shift from this model, like more like biomechanical, biomedical model, to the biopsychosocial model. We will still consider all the biological aspects, but we have to understand how is in the interaction between psychological, cognitive, emotional, and social aspects of pain, that the interaction between these aspects will probably be much more important than one like a biological isolated aspect in terms of chronicity and disability.
Wow. So you became a physiotherapist, but also a psychologist and a mental health provider. So you connect so when you say cognitive is what they're thinking, what they believe. So the biopsychosocial model, we talk a lot about this in the channel, is you consider the biological, but also the psycho and the social, integrating all of those. We heard about this the whole morning.
Exactly.
Yeah, at the conference here the morning, they talk. Exactly. There were excellent talks about the biopsychosocial model. So can you talk again about the MRI? So what is wrong with someone look at an MRI or a CT scan or an X-ray, and they say, "Oh, this is wrong with your spine, and that's why you have pain because there's this abnormality." And you were saying that may not be the case.
Yeah, most of the time, non-specific chronic low back pain is the pain that is not driven by the pathology, although we can find these abnormal findings in the MRI scan. So it's very common. Disc protrusion, for example, you're going to see like half of people in their 50s having disc protrusion. So it's very common, and it doesn't change the outcome of treatment. So and there is evidence that performing an MRI scan very early, for example, less than 6 weeks after an acute episode, there is an escalation of exams like electroneurommyography, opioids use, anxiety, injection, and surgery. So we have to it's not to neglect completely the MRI, and of course there are at 5% of the patients with chronic or with low back pain, they are gonna have pathology. So we have to consider that, of course, but most of the times people with chronic non-specific low back pain, most of the time the people that are suffering more because they don't have a diagnosis. The healthcare professionals, they don't understand them, and they are trying all the time to find a diagnosis. They're still trying. So there are people that don't accept non-specific low back pain.
I have patients that they probably have back pain for 20, 30, 40, 50 years, and they're still trying to find what is wrong with my back. Yeah.
Exactly. So with the aim of neutralizing the nocebo effect, the nocebo effect is the opposite of the placebo. When someone says that your spine is damaged or is out of place, needs manipulation, needs fixation. Like I need to put my vertebra at the right place again. So those are terrible thoughts for a patient with chronic low back pain.
Because first, it's not true.
Exactly.
Second, they think they have something really structural,
Yeah.
and then they will try to protect that spine.
Exactly. So this protection we call maladaptive functional behavior. That is like a protection that's not helping. It's not helping, and it is probably increasing pain and disability. So the treatment should be based on trying to help patients understand that if you go back to your natural way of moving gradually, you have a good chance to recover your functional capacity and your quality of life and decrease
Reduce the disability.
and pain.
So, Ney, why don't you tell us about the exciting research that you're doing? You were doing a lot of studies, and especially with chronic low back pain, spinal stenosis as well. So, why don't you tell us what are these therapies that you were studying and what are the results?
The therapy I have been studying is called cognitive functional therapy, or CFT. It is physiotherapy-led intervention based on the behavior psychology and neuroscience direct to the physiotherapy practice. So it's a mix of those areas, and it's a behavior approach that can be delivered by physiotherapy. Consider the evidence, the scientific evidence we have for that includes all this evidence to treat patients with chronic low back pain. And there are three main components for CFT. The first is making sense of pain, which is a process of listening to patients' stories and trying to understand all the biopsychosocial, the interaction of biopsychosocial factors in a way that is patient-centered to help them. Since they're, for example, we are talking about chronic non-specific low back pain. How can we explain that? Sometimes it's hard to explain because it's not specific, because we don't have like a pathology to say that your problem is this and we have this kind of treatment. No, we are gonna have to work out with the patients to help them understand that there are psychosocial factors and there are physical factors contributing to the onset and also to the chronification. So a timeline with all these factors that influenced the chronicity of pain is very important. So this is the first component of cognitive functional therapy. The second one is exposure with control. Exposure with control is is the patient. All patients have some functions, some limitations, and we ask them about that. And for example, there is a big group of patients with chronic low back pain that they avoid bending over. So
I have seen many patients like they would bend like this,
exactly,
and instead of naturally bending. Yeah.
exactly. So, for example, if a patient has has maladaptive functional behavior related to bending over. So we are going to try to help them to do the same movement in a more relaxed way, trying to recover the natural, his or her natural way of doing without muscle guarding and without increasing pain. That's why it's exposure with control. We have to check whether they are contracting abdominal muscles, because we know this kind of protection decrease the pain threshold. And then we ask them to do this movement. And when patients are able to do this movement again, they have something that we call is expectancy violation. And they get surprised.
Nice surprise.
And this surprise, after that, we are able to explain, to help them understanding, because we convinced them.
They convince themselves.
Exactly. We help. Exactly. They convince themselves doing an activity or movement that they had been avoiding for sometimes years. And so this is we call expectancy violation. And then they have to practice that
homework
to do, and to incorporate that in their daily lives. So this is the second component of CFT. And then the third component is lifestyle change. We know that sleep disturbance, like obesity, lack of physical activity. We know that smoking, all these aspects, they contribute for a low pain threshold. So it's very important to try to tailor an intervention to help patients with on their lifestyle, like for example, it's good to give advice centered on the patient. Like, for example, if I love to dance, this could be an activity. Although we sometimes in the past, maybe dancing is not good for your back. So since there is no evidence that one activity is better than the other, we can use the activity that the patients love to try to motivate them to go back to the activity that they had stopped doing. So this is something that we call bright spot, to try to find the bright spot. What's the bright spot? It's something that you were used to do in the past before pain, that you loved and you stopped because you forgot. Sometimes patients forget about that when we ask, it's been a long time since the last time I was able to do that. And when they speak about that, they smile. And so, that's it, that I'm going to help them to do that. Imagine that I heard you talking about opioid, that they are 100 times more potent.
Our own endorphins, 100 more times more potent than pills that we can take.
So imagine if we are able to elicit, to like evoke the bright spot, and the person starts to, how can I say, activate their natural pharmacy again. So this is the main reason why lifestyle is very important. Like one of the most important reasons is that if you have a good lifestyle, you have like your chance of having a nervous system that is able to inhibit pain increases. So that's why this is the third component of CFT. So all these components, to achieve a good result, we have to enhance the therapeutic alliance all the time. So we use techniques from psychology like mirroring, like silence. Sometimes you have to use silence, and sometimes patients cry. So which is completely normal. Validation. We always validate patients' stories, like
Believe what they're saying.
they are saying their pain, and so it's normal because sometimes they think that they are the only people with that. So it's a very interesting approach. Uh, Speaking as a physiotherapist, speaking at 25 years uh, of experienced physiotherapist, and my research, our latest randomized clinical trial, assessed investigated, was the first trial to investigate the efficacy of CFT versus a sham placebo control. It is a piece of the puzzle that was missing. Like we have many clinical trials investigating the effectiveness against other intervention, but we hadn't have a trial with CFT compared with placebo, for example, a sham. So since it's not possible to have a perfect placebo, like an intervention that is behavioral, like a placebo of CFT, you use the photobio modulation. Oh, I forgot. The laser. It's a laser that was unplugged. There is only the light, but it was not activated. Either way, if it was activated, it would be a placebo. It's considered a placebo for chronic low back pain. So we asked people by the end of the trial to if they believed in an active intervention. In both groups, we have about 60% of people believing that they received an active intervention. So the placebo worked. And the results showed that CFT was efficacious for treating patients with chronic non-specific low back pain. In terms of pain reduction, we have at 1.8 points of pain reduction in a scale from 0 to 10, which is considered clinically important, and 10 points of disability reduction in a scale from 0 to 100, which is also considered clinically important. And these results were sustained until the 6-month follow-up. So it was our latest clinical trial. We had already performed 2 other trials in Brazil, and these other trials are being quoted in the recent systematic reviews. But the latest and the most important was this one that had just been published.
Are they open access, these publications? People can read the full paper online?
Unfortunately, it's not open access, but I can provide you the...
No, but I'll put the link of these publications in the description of the video. So, but if they want to read the full paper, they can ask a library to open for them.
Yeah, and I forgot to say that the strengths, one of the most important strengths of this trial was that it was conducted in Brazil by a research group independent of the group that created CFT. It's very important to replicate studies in different domains. So one critique is that most people they create a method and they perform a clinical trial, and when other groups are trying to replicate, it doesn't work the same way.
They don't get the same results.
So it's we can say that the external validity of CFT is very surprising with because we have a very good result in a mid-income country, also in a context that there are people from all social conditions.
Yeah, it was a context that was different from the one that it was developed.
Exactly.
Ney, last question. I think people would be asking, because my audience is from all over the world, is it easy to find a physiotherapist in the world that knows CFT?
Unfortunately, is not, because it's a novel approach, and there are hundreds of approaches for chronic low back pain physiotherapy. Unfortunately, we are still struggling with the fact that pseudoscience is very prevalent. For example, we conducted a study in Brazil to check whether the websites, the how can I say, the most important websites, like from government and every institution that are considered reliable, and most of them were providing not evidence-based information, not that good. So it's hard to find, but we hope this idea of a biopsychosocial based intervention for physiotherapy is spread around the globe. I hope in the future people will find good information, like not information that's saying that they have spinal, like a bad back, and there's no, the chronic low back pain is something that you're gonna have to, the disability, you're gonna have to deal with the disability your whole life. So you know that sometimes there are people that we can partially help, but why don't you say that there is always hope for improvement?
So, Ney, thank you so much for talking to us today. I think this is very in synchrony with what I talk on my channel here, that we want to give messages of hope for people with chronic low back pain, that the MRI is not always what they show there is what's causing the pain is more a coincidence. And the back is a strong organ that we have. The spine is a strong organ that we have in our body. And they can do like simple changing their thoughts, the way they view their diseases, their pain, the way they interpret can help them a lot. Changing that interpretation in their mind can help a lot. So I think you went full circle. You wanted to help people with chronic pain. You found this intervention. You are applying. You did research, and now you're able to help people with chronic low back pain. You feel that you have fulfilled that desire to help people with chronic low back pain now?
Yeah. I'm feeling like as people that like that I helped, physiotherapists that I helped, they say I'm feeling the same. I will always be. I hope I will always be surprised with patients' improvements when I am able to help them. This is the best outcome I could achieve, to help people recover their quality of life. So this intervention is very good for
I
this.
find, yeah, I'm not a physiotherapist myself. I'm a physiatrist. I also touch patients and I also treat them. And it's so satisfying when we see that they see their condition differently and they believe in themselves and they say, I can do it. It's so satisfying. So thank you so much, Ney, for
Thank you
talking to
for
us
having
today.
me.
I will link, you are on Instagram and you're also on YouTube in Portuguese, and I will link his social media on the description of this video here. And for those of you, remember, we are not here to give you medical advice. It's really important that you talk to your doctor, to your physiotherapist. They are the best ones to know you, so follow their advice. This is more for education, to open your minds about what are the possibilities. And maybe you can recommend to your physiotherapist to take some courses on CFT, to read Ney's papers, and get some more options to treat your low back pain. But if there is any emergency when you are watching this video, please turn off the video and go to the nearest emergency department or call an ambulance. And don't forget to subscribe to this channel here. I'll always try to post new things to bring new innovations for you to treat and manage your chronic pains. Thank you for watching today. Goodbye.